issue.
Yeah.
And the number of tests I think are very less probably, है ना sir?
Yeah.
So the only point मुझे ये लग रहा है कि जितना हम timing of sampling and result में कर लेंगे, उतना it will be more efficient system to run.
Yeah.
तो आपने सर आपका NABL का हुआ सर अभी?
NABL कल next week हो जाएगा. अभी staff, I think DMC staff also were in Patiala for the training.
हाँ सर.
तो Monday कुछ document हमने submit करना है. Then most probably next week inspection.
हाँ 2-3 दिन में हो जाएगा सर. तो आपके पास open machine है या closed सर?
It's closed. We have 2 areas. The new one is in the new area, the separate molecular lab.
Okay.
Yeah, that is well done. The old one extraction के लिए use करना पड़ेगा.
Okay sir.
Dr. Mohan.
Yes sir.
Yes sir, आगे. Sir morning. Good evening sir.
I think can we see Dr. Puri?
No sir, अभी तो 2 मिनट पड़े हैं मुझे तो.
Because उसको आपका number मैंने दिया अभी. He wanted your number, of course connection I had sent to him. And so let us how many we have from, I can see CMC. What
CMC में है sir.
So I have sent to the critical care people to join. Yeah.
Now what Patiala, Amritsar,
सर मैं डॉक्टर पुरी से बात कर रहा हूँ सर अभी.
हाँ अच्छा करो. पटियाला का नहीं कुछ पता?
जी सर. मैं नहीं सर अभी हमने तो ये तो सिर्फ लिमिटेड है ना सर, सिर्फ 25 और 50 के बीच में सर. तो ये फॉरवर्ड कर दीजिए सर सबको. वी आर जस्ट वेटिंग फॉर यू सर. जब भी आप करोगे तब शुरू करते हैं सर. जी सर. सर वो
मोहन जरा देखो बाकी मेडिकल कॉलेजेस का कैसे है? पटियाला, अमृतसर, फरीदकोट. अविनीश जरा देखना पटियाला, अमृतसर, फरीदकोट वगैरह. अच्छा दे आर ऑल कनेक्टेड. मैं देखता हूँ, मेरे को नजर नहीं आए. हाँ पटियाला भी देख.
सर फरीदकोट इज कनेक्टेड.
ओके गुड. फरीदकोट इज देयर. तो आप जरा पटियाला को भी कराओ फिर. ओके. Mohan, let us see that there is somebody connected from Amritsar. Which are Amritsar? Please, anybody from Amritsar?
नहीं सर.
वो कह रहे हैं connected है. Hello.
सरजू.
Hello.
सरजू कितने जने कनेक्टेड अभी तक?
37 लोग हैं.
37.
अमृतसर से कौन है?
हेलो अनीता.
हेलो अमृतसर. Anyone from Amritsar Medical College?
Dr. Chatrat is there.
Sorry?
Dr. Chatrat is there online from Amritsar, I think.
Okay, Dr. Chatrat, can we hear you? Dr. Chatrat?
Yes, sir.
Is Dr. Chatrat there?
Yes, sir.
Okay, doctor, welcome and thank you. Your colleagues are there?
No, sir. I am operating from my mobile phone. They will be operating from their mobiles.
Okay, but make sure that they are all connected. You can be there. But from Patiala, who is there from Patiala? Anyone from Patiala Medical College? Dr. Vishal Chopra. Anyone from Patiala? Are you not connected? You are there? आपको बताया नहीं है क्रिटिकल केयर की आज है. डॉक्टर पुरी कर रहे हैं कि यूएसए से है लड़का, दोनों जने हैं वो कर रहे हैं प्रेजेंटेशन. आपको नहीं बताया किसी ने? आप जरा पता करो. पटियाले वो नंबर भेजा हुआ है, जरा अवनीश से बात करो. ही वाज टू सेंड द नंबर टू एवरीबॉडी प्लीज.
Hello.
Hello. Sir.
Sir.
Sorry.
Good evening, sir.
Can you give your name, please?
I'm Dr. Puri, sir.
Okay, Dr. Puri from Patiala.
Chandigarh, sir.
Oh, Puri sir, welcome, welcome, Puri sir. Welcome. I'm just trying to find our connection from. Let me see if I can get the. I know Amritsar people are there.
Yes, sir. Faridkot is there,
हाँ जी
sir.
sir.
Faridkot is there. Somebody.
MC, CMC is there.
Yes sir. Dr. Ravinder, sir, I have called the principal and he's calling up shortly. Everyone
Yeah,
will
but
be
why
there.
there is a communication issue with this? साढ़े साथ आपका देखो phone post तो करना पड़ेगा यार.
सर वो तो सुबह ही मैंने उन सबको कर दिया था और प्रिंसिपल इज आल्सो
बताओ ना कि आपके लिए तो हम
हाँ
कर
जी
रहे हैं.
हाँ जी हाँ जी
कोशिश करो प्लीज. हाल चोपड़ा कह रहा है मेरे को तो पता ही नहीं है. इसको
it was in the group. The principal has put it in the official group and for everybody.
अभी बता दियो देर आई कैन सी नाउ. तो आप जरा बताओ इनको प्लीज. हैं ठीक है.
Yes sir. Yes sir.
Okay, Dr. Puri.
Sir, I have with me my younger faculty, Dr. Rajarajan.
Puri, I can't see you fully. I can only see your spectacles. Can you be? That's better.
Welcome, sir.
And
Evening,
Puri,
sir.
you have your colleagues with you.
Sir, I have Dr. Rajarajan with me and some of the people who were working in the COVID ICU presently.
Okay, good.
I have
But
asked them.
is your former colleague Dr. Kataria joining us from USA?
Sir, Dr. Kataria is joining us from USA, sir. I'll just ring him up.
Hello, good evening, Dr. Tarwar. Dr. Puri, I'm here. Your microphone is muted.
Sorry. Dr. Kataria. Sandeep is here, sir. So, so how is everything, Sandeep, in US? Your hospital, everything's fine?
Yeah, we are still in the peak week, and then hospital is not releasing the mortality data, but we are seeing a lot of mortality now.
Anyway, I think see what I think Sandeep, I'll call Alok once we are through with the preliminary slides. Will be presented by Dr. Rajarajan, and I will just. So can we start, sir? Yes. So so we can start with the sir.
Just ask everybody to mute their mics,
Okay, so we are starting on with the slides. As we know that the pathophysiology of coronavirus includes a significant amount of pneumonia, hypoxemia, and a lot of patients will be needing ICU care, advanced oxygenation ventilation supports, and mechanical ventilation, including ventilation, NIV, and invasive ventilation. So let us learn a bit about the various clinical presentations of coronavirus. We know that the mild form of the disease presents with cough, low-grade fever, dyspnea, rhinitis, or GI disturbances, but there is very little hypoxemia. However, the normal pathophysiology of the disease is also marked by one, a dysregulated host immune response, a so-called cytokine storm. There is also microthrombosis, and there is lung involvement, which we'll be learning about later. So increase to a moderate disease is signaled by fever. And if this progression occurs earlier in 1 or 2 days instead of 7 days as is usual, it signals a more severe form of the disease. More severe disease is signaled by tachypnea, hypoxemia, worsening PF ratio or worsening respiratory pattern. And biochemically, the markers for this are an hyperferritinemia, increase in C-reactive protein or worsening imaging, requirement of ventilation or vasopressor support for shock or organ failure signals a critical disease. how we are managing the patient in PGI is based on a triage, in that patients who are not hypoxemic on room air are going to isolation wards, whereas patients who are more hypoxemic and requiring oxygenation but not tachypnic are ideally should going to an HDU, and patients who are tachypnic also and requiring ventilation will be going to an ICU. In this case, monitoring of the oxygenation of the patient is essential, as the patient can have silent hypoxemia. Patient can have a very normal respiratory pattern, appear very comfortable, but still be hypoxemic. Again, a biochemical monitoring is very necessary, so that apart from the regular workup, that is the complete blood count and biochemistry, we need to be regularly looking at the disease severity biomarkers, that is the C-reactive protein, ferritin, D-dimer, which is elevated, and also lactate for hypoperfusion, because myocardial involvement is also there and patients can be in shock, which can be cardiogenic. We'll learn more about this later, but cardiac biomarkers like troponins and BNP should also be followed. Since we'll be using hydroxychloroquine, G6PD should be monitored, and other parameters should be monitored, appropriate cultures, procalcitonin, monitoring for the infection. We are all aware with that. For regular monitoring, CRP, ferritin,
I cannot hear.
जी सर
हेलो
हाँ जी सर
उधर म्यूट हो गया सारे सुनी दी आवाज
ਉਹਨਾਂ ਡਾਕਟਰ ਪੁਰੀ ਬੋਲ ਰਹੇ ਸਰ ਉਹਨਾਂ ਦਾ ਅਨਮਿਊਟ ਹੈ
can the host kindly mute all in this case?
हाँ सरजू वो अनम्यूट है
Okay, I'll continue. So the initial support is with oxygenation. If a patient starts becoming hypoxemic, we'll start with oxygen support, with ideally by a nasal cannula with titrated oxygen flow, 2 to 5 liters per minute. The next step would be a use of a face mask with a reservoir bag, the non-rebreather mask, which we can see here. And the next step for hypoxemia is self-proning. As there is differential lung involvement, self-proning has a very good effect, which we'll discuss later. We need to be careful about using a venturi mask or a high flow devices, because or a high flow nasal cannula also, because there is a very high risk of aerosol generation, which can cause the spread of the disease. This, what we can use, will depend on what kind of PPE or negative pressure rooms we have available in the current setup. But ideally, we should be using very low aerosol generating devices. If you move on to the next slide. Yeah, we can see in different procedures. Here we can see with the same venturi mask, there is more aerosol generation with higher flows. And among various devices, we can see that NIV or nebulization has very high aerosol generation. Whereas the simple mask or a venturi mask and nasal cannula have progressively lower aerosol generation and spread. And the non-rebreather mask is lowest. So in case we had inadequate PPE or containment protocols, we can try using the simpler forms of oxygenation support. Now we need to know that the aerosol generating procedures like mask ventilation, open suctioning, even extubation, a coughing by the patient, all generate aerosols, and they are dangerous procedures. So we need to plan adequately for that. And this needs to be in a large room with very good airflow. The doors have to be closed. The providers should be in complete personal protective equipment. The ceiling fans should be off. There should not be AC circulating the aerosols throughout the building. If we can create some negative pressure with exhaust fans on, and minimum number of personnel, trained personnel should be in the room. The guidelines should be less than 2 or 3 maximum. This should ideally be done in the ICU by a trained team with ready protocols. the ventilator has to be allowed available because a patient on AMBU will have high aerosolization and should not be allowed.
Dr. Subhashri, Dr. Sandeep will join. Sandeep, are you ready with your intubation protocol? Sandeep.
I think we can go over this, and then I'm making notes, and then we can. I will go back on 2 points.
Okay.
So
okay.
that
Fine.
once we finish.
Fine.
Okay. So AMBU should not be allowed, and some clear role allocations should be done. Equipment should be checked so that there is no confusion. We know the usual indications for intubation, so that a PF ratio persisting less than 150 for 2 hours, or a saturation of by FiO2 ratio less than 180, so that SpO2 is less than 90. So we can go by that clinically, or we can look for other clinical indications like neurological deterioration or cardiac arrest, obviously. But we should be ideally doing elective intubations. Can I have the slide? Yeah. Equipment, we should be using a disposable ventilator circuit, obviously, and we should be using a HME filter or a viral and bacterial filter. 2 filters should be used, one at the patient end at the Y-piece, another at the expiratory port, so that we are not contaminating the ventilator. We should also use an inline closed suction device, so because open suctioning obviously will expose all the caregivers to dangerous aerosols regularly. A capnograph should be used for confirmation, and it should be applied to the circuit, and this should be after the first HME, closer to the ventilator, not on the side of the patient, so that it is not contaminated. All of this circuit has to be assembled, tested, and calibrated before we are proceeding with the intubation, because once the patient is on the ventilator, we should not disconnect it. Again, our aerosol, after airway assessment, the airway equipment should be ready. Video laryngoscope has been recommended for this intubations because there is more distance from the performer to the intubating caregiver to the airway. In this video laryngoscope, you don't have to peer in close. And the endotracheal tube should be clamped. This is a very interesting modification that has come up. We should use a normal hemostat or artery forceps to clamp the tube, so that even if the patient coughs into the tube, that does not come into the environment. Now for intubation, obviously the most experienced operator should go, because the aerosolization has to remain minimum, so that it has to be a very fast procedure. We pre-oxygenate, ideally without positive pressure ventilation, on the patient's own spontaneous ventilation with 2-hand technique, and just holding the mask and giving high flow oxygen. After that, a rapid sequence induction is preferred with a high calculated dose of paralytic agent, succinylcholine or rocuronium given. And once the tube is in place, the cuff is inflated, the endotracheal tube declamped, and the ready ventilator circuit that we have already prepared directly connected, only then the ventilator is switched on. So a closed ventilator circuit is established, and only then the ventilator flow comes. We should not be doing anything otherwise. We should not be confirming with AMBU. So this is a major practice change we have to enact. If you go on to the next slide, after ventilation, we'll have...
Sandeep, will you join? Sandeep.
Okay. Thank you very much, Dr. Sergio, I believe. I hope I didn't get your name wrong. So very good points, very good slides, actually. So few points that, like you mentioned, the most experienced person or a team should be doing the intubation, and ideally they should do at least one drill so that they know what to expect, because it's one thing in theory, and it's a different thing in when you go there. And second point I mentioned was a number of personnel. The 3 is ideal, that's good, and I would add that there should be one more person outside the door, just in case you run into some difficulty to have somebody to help. So we do have a team of 2 people, the one person attending like me who goes inside, and the nurse anesthetist who stays outside. So if you need anything, you when you make a team of 3 people, it's very good practice to tell them what to do, actually, because most of them, if they're doing first time, they will be very scared. So tell them their definitive roles, who's going to push the medications and who's going to manage the ventilator. Like you said already, everything should be ready. Vent should be already ready, and then so that you secure the airway and isolate the airway from outside environment as quickly as possible. Uh, uh, the other thing you mentioned about medication is we need to do a rapid sequence induction. And before we do that, let me talk about a little bit of pre-oxygenation. So depending on at what time you are gonna be intubating, these patients are really hypoxic. So you have to give adequate time to give a pre-oxygenation. Sometimes you have to start at saturation of 74, 86 or something like that. So with this pre-oxygenation, it's very hard to achieve ideal situation. So what we do typically is that after 2-3 minutes, if we start seeing that the saturation is starting to pick up, that is another cue that patient is almost getting ready to be intubated. And once you start the induction, the patient is definitely going to go desaturate, maybe up to 40s, 50s, depending on how much reserve or FRC he has. So at that time, there's normal tendencies to do a bag mask ventilation. But if you are confident enough in your airway and the patient airway looks good, I would recommend keep moving forward, because your best chance is to secure the airway as soon as possible. Because if the saturation is going down, once you establish airway, it will pick up with some lag in there. Because we as anesthesiologists have seen desaturations temporarily, and they're okay. We can tolerate that. Regarding succinyl choline, just be careful about a little bit. Sometimes these patients can present a little late and had already acute renal failure set in, and we might or might not have a level of potassium in this patient. So if you think that airway is not difficult, we can directly go ahead with rocuronium if you're available. And at the time, also make sure you use a high dose of rocuronium, because you want to make sure that the adequate paralysis is achieved sooner than later. I like the idea of clamping the attitude, but if you're using a video glide scope, you need to have a dedicated stylet. So that may not be applicable in that scenario if you're using a video laryngoscope. There are a lot of information on the net about a lot of videos. So before we go, you have to make your own protocol instead, like what you're gonna do for your personal protection. So we started with some different, we ended with some different. So, but basic thing include that there should be an, like what we're doing at this time is that there should be an N95. And since we are using N95 for the whole day or whole shift, so we cover that N95 with another surgical mask. There should be eye protection, eye shield, and your other exposed areas are covered. Earlier, we were not covering our exposed areas such as neck, but now we have borrowed some ortho striker space suits, and we're using that. And once we run out of those, I don't know what we're going to use, but definitely we need to have some plan and for our personal protection. And another thing is that as soon as we connect the ventilator, we need to do some recruitment maneuvers, because we already have lost a lot of lung volume. But that is only temporary, because we will be later discussing about how to manage the vent in these cases, because the ARDS or whatever lung problem these patients are, maybe a high compliance one or low compliance one. So depending on that, if the compliance is very low, we need to make sure that we are not doing more lung injury by high volumes and high BP. And also once you do that, you need to make sure what instruments have you used, and proper cleaning and getting ready for the next one is very important. Thank you.
Yeah. So
hello. Were you guys able to listen to me or no?
Yes, we could listen. We could get you, sir.
Oh, okay, thank you. Thank you. You can go ahead with your presentation, and then we can take questions after that, I think.
Okay, sir. Yes, sir. Dr. Varun would be presenting on the ventilation. He's here. Yeah, Dr. Varun is here.
So I think
Dr.
I'll
Varun, we cannot
continue.
hear you.
Varun is not here. So Rajarajan. So ventilating COVID-19 patient, we are still learning. That's one thing. The other thing is the pathophysiology of a patient also continuously evolves. So in general, when we start ventilating, we put the patient on a pressure control mode or a similar mode. We give a tidal volume of 6 ml per kg of predicted body weight. For predicted body weight, we have formulas for males and females. We keep a respiratory rate. We start at around 20 per minute and we titrate it to a pH of more than 7.2. We titrate the carbon dioxide and then the respiratory rate. We keep a plateau pressure of less than 30 centimeter of water. So regarding positive end expiratory pressure and recruitment, it differs between the patients. We measure the compliance of the lungs, and when the compliance is more than 40 ml per centimeter of water, we give low PEEP and we avoid recruitment. And we sedate and paralyze patient based on clinical monitoring and neuromuscular monitoring. So these are the two phenotypes we encounter in patients with COVID-19. The first one is the type L, which they have the low elastance, low ventilation perfusion ratio, low lung weight, and low recruitability. And this is how the CT scan of such a patient will look like. So next phenotype is the type H, which has a high elastance, a high right to left shunt, high lung weight, and high recruitability. And this is how the CT scan of type H patient will look like. So most of the patients, they initially have a L type of lungs, and they may improve or they may worsen. So when it worsens, it is because of it is hypothesized to be because of increased patient respiratory effort, which leads to lung injury. And they ultimately end up with the type H phenotype with the ARDS-like picture. So the lung ultrasound in COVID-19 patients is pretty useful. It can be pretty useful if one is experienced in it. So this is the CT scan of one such patient who has subpleural consolidations. And on the ultrasound, you can see over here, echogenicity is below the pleura. On the right side, we have a ground glass opacities on the CT scan, and the corresponding finding on the ultrasound is D lines. So even if by conventional ventilation, we are not able to maintain adequate oxygenation, one option we have is proning. The patient, ventilating a patient in the prone position. In this, it is hypothesized to cause more homogeneous aeration and it improves the oxygenation. It works best when it is done early within the first 48 hours, and it should be performed for at least 16 hours every day. When doing this, we need to make sure that the tube does not get displaced. There is no increased abdominal pressure. We should avoid pressure source. We also need to remember that this is a labor-intensive procedure. So if the oxygenation is not improving, even after proning, we have a few more options left, which include inhaled nitric oxide. Here, the nitric oxide is delivered to the patient through the ventilator. And the next step would be the extracorporeal membrane oxygenation. Both of these are expensive interventions. When ventilating a patient of COVID-19, we also need to have separate protocols for circuit disconnections, which can be either deliberate or accidental. When such disconnections happen, we need to give additional paralysis to the patient so that the secretions don't come out. We allocate roles to specific people, and we make sure that they do it in a rapid manner. When such a patient has a cardiac arrest, we use mechanical compression devices, because when sweating happens, it can cause the breach of the PPE. The sweat can carry the organism to the nasal or oral mucosa. So over to Dr. Subrasish.
Yeah, so as we know, as everybody has discussed, what we are mainly giving these patients is hydroxychloroquine or lopinavir, ritonavir, which are antivirals, or polyvalent non-specific vaccines like Immunovac. We're giving the general care like enteral nutrition, stress ulcer prophylaxis with PPI or antihistaminics. or DBT prophylaxis with either unfractionated heparin or low molecular weight heparin, or intermittent pneumatic compression devices. And if patients are with low platelet count, fondaparinux can be given. Ascorbic acid or thiamine are also being used, as are various other agents. And actually, regarding what to use, there is quite a confusion regarding this, because there are very few studies coming out right now. A search through the preprint database shows almost 244 ongoing trials, but few studies have been published after peer review, and most are preprints. Even a lot of the studies on hydroxychloroquine and azithromycin is preprints. So from the large bodies, we have very few recommendations. The WHO only says not to give steroids, which was based on the initial data coming out of China in the initial months. Later data from the US and elsewhere has been promising regarding steroids. The Surviving Sepsis campaign says to use steroids. And if we look through the various protocols being followed in various institutions in US, UK, and Italy, we can see that the basic management through all the stages of coronavirus remains the same. They are using paracetamol, stressor cell prophylaxis, anticoagulation. Almost everybody is doing it. Other than that, some people are giving supplements like vitamin C, some people are giving immunomodulation, and since cardiovascular involvement is there, some people are giving statins. At various stages, under various clinical trials, they're also giving antivirals like remdesivir, sarilumab, or IL-6 inhibitors. At the cytokine storm, when that is happening, there's actually a cytokine dysregulated immune response causing a cytokine storm in the pathology of the coronavirus, which signals a rapid decline in the patient condition. And at this stage, tocilizumab, IL-6 inhibitor, is being given by a lot of groups, and some groups are also using steroids to give this or prevent this. So we should look for the data coming for this in the coming times. Other than that, if the patient has specific signs of bacterial superinfection, then we can give antibiotics, but after proper cultures. In cytokine storm, we can give tocilizumab, but we have to rule out tuberculosis. And we have to anticipate the cytokine storm, which can be signaled by a rise in ferritin or a rise in C-reactive protein or rapid chest X-ray or clinical worsening. So the main thing here is to look forward for the evidence and just watch for the cytokine storm. So Dr. Rekha will be telling us about the management of shock in COVID.
Dr. Rekha, just wind up. After this, Dr. Anup, who has joined us from New York, he will also give his viewpoint on the cytokine storm and how to prevent the ventilator. As you know, the ventilator is the ultimate thing, but our aim is once your patient go on ventilator, the different centers have shown the mortality varying from 50 to 90%. Very few people have shown a less than 50% mortality. So if we can avoid ventilation, that is the best thing. But if patient has got hypoxic, how to prevent the severe hypoxemia? I think Dr. Anup has got his, in his armamentarium some usually practice drugs, but the way these are to be used, he has his own way. We'll discuss with him about that. And Dr. Rekha, I'll just cut short. I'll ask Dr. Anup to speak before you talk about the management of hypertension. Anup, are you there?
Yes. Can you guys hear me? Has anyone hear me?
Just introduce yourself.
Hi everyone. My name is Anup Singh. So I work in Lenox Hill Hospital. I work here in New York City, Lenox Hill Hospital, in a critical care setup, and of course, New York is epicenter of epicenter. So the number of patients we have in our whole system is somewhere around 3,000 something. Total patients which we have seen in our system. In my own hospital, our number of patients is around, I think, 700. I think Dr. Puri, what you said is actually, is the way to go. I think what Italians, as I said before in my, comment, like what Italians and Chinese taught us as a very good experience. But if we go that route where our mortality is very high. So the NEJM paper came from Washington State, from US, says mortality of US patients going on ventilator is 50%. The centers in New York, which I'm getting, their mortality in ICU is 70%. I just finished the mortality data in my ICU. Our ICU mortality data is 20%. And so it's much, much better than before. But I completely agree with Dr. Puri is that we should not let these patients go into on ventilator. Our goal should be to prevent hypoxia much, much better. Few things I want to, before I go talk about cytokine storm, I was looking at presentation for last few minutes only, but few points I found out I want to share with you. These patients very, very high risk. So in our retro, we will publish this study, but for now I can give you some preliminary, like whatever, if we have ordered 50 DBT studies for these patients, around 25 of them are being positive. Let me put it like 20 to 25 are being positive. That doesn't mean that other 25 which are negative doesn't have PE. And on top of it, that doesn't mean the prevalence is only 40%. The prevalence of thromboembolism in these patients is higher, even with prophylaxis with Lovenox once a day for BMI less than 30 and Lovenox 40 milligram BID. So prophylaxis doesn't work. So we are entering into this randomized controlled trial where we really want to find out on the basis of D-dimer what is the mortality. But high risk of what we are doing, and even high risk, we are fully anticoagulating them in ICU, just to give you and there are multiple protocols which you can use, but these patients have higher risk. And other thing is, I think there was some talk about shock in these patients. I can tell you, if only COVID, it will not cause septic shock. I'm telling you right now, the only thing it might be that if they are continue have fever, there might be some hypovolemia initially. So we have to be a little bit careful, because I still don't think it is ARDS. I refuse to believe this is ARDS. We are making them ARDS by keeping them on ventilator and intubating them early. But please make sure that you as far as them being shocked, if shock happens, try to find other cause in these patients. Any patient in my unit who is in really bad, you might find little bit of levofed and all those things because they are on propofol, they are drug induced, that's okay. But if they are going high doses of levofed, required vasopressin, try to find secondary cause in these patients. Shock is not is not what happens in these patients. Hypovolemia can be, you can take care, but try to keep them even input output, because that's important. Now let's talk about what, as I said, the mortality at this point of time of New York City. Any patient who's coming to the hospital, out of 25,000 patients coming to the hospital, 5,400 death has happened, which is basically, if you calculate, somewhere between 20 to 25% of the patient entering to the hospital are dying. The mortality data at our place in Lenox Hill at this point of time, in few days back, was 8% only, but I think it has increased recently to 12 to 13%. But it is still less than 23, 24% at other places. What our plan is this. What we have done is, we are trying to predict this cytokine storm. And I think I was looking at the guidelines which you were saying. I think the way to detect it is this. One thing which has to be 100% present to call something cytokine storm is hypoxia. And that hypoxia is, you can say any hypoxia going somewhere 3 to 6 liters of nasal cannula. The way this is something, if it is present, it means the inflammation or VQ mismatch is going into the lung. And that is the time, this is the time to act very fast. Or if someone coming on room air, these patients deteriorate like very, very fast, and they will go from 0 liter oxygen requirement to 6 liter within 1 hour, and they get intubated within 3-4 hours. If this is what is happening, you predict zero going their oxygen requirement from 0 to 2 liter to 3 liter. This is the time to act. Because if you don't act, then they will intubate it, and we are beginning to sorry. Okay. And the other thing what I want to say is to predict it. Hypoxia, second thing is they will be having continuous fever. Okay, so if these people are having continuous fever, this is another indicator that they are in cytokine storm. I have seen personally, so I would say presence of hypoxia. Second thing is presence of fever or a CRP level which is doubling. It doesn't have to be a delta of 15, guys. It doesn't have to be a number of 30. It can be a CRP doubling from 5 to 10. But that is something you will see. But if someone is coming already with a high CRP, that is another marker of someone in storm. To me, my experience says is if you give, there are few patients who remain on 2 to 3 liters and they don't progress much. Very few of them, but most of them progress. But if we give them tocilizumab, which is anti-IL-6, at this point of time, I'll tell you, we didn't have enough, but we had for some, I had done it for few people. One of them was our medical resident who was 87% on room air. And we know that patient is the medical resident was in storm. We gave tocilizumab. Patient went, she went home 2 days later. I didn't give her steroid at that point of time. There was there is this trials going on. There is a big hotshot CEO who decided to come here. We gave him a drug, tocilizumab, which is actually his competitor company's drug, and the guy went home next 2 days, and he was getting hypoxic to 6 liters. He did not get steroid. So what I'm saying is, if we use tocilizumab really early, we can stop the storm and then stop that VQ mismatch which is happening. To me, I completely agree with Dr. Puri, and I think it is a perfusion mismatch. This is what is happening due to the cytokine crowding in the pulmonary vasculature. That's why their compliance are perfect. You will see these patients, if you intubate them, doesn't matter how much PEEP you give to them, 15, 16, 17. I don't give that much PEEP, but even if you give you look at their driving pressures, you look at their plateau pressures, they don't go above 20, 25. That's initial stage I'm talking. But if you let them having trauma from ventilator, then they will turn into ARDS. Other thing, and then if someone is hypoxic to a point when they're really requiring non-rebreather, we give them tocilizumab, but at that point of time, we start them on steroid. I think other way around, when we did not have enough tocilizumab in our house, there was a time on weekend we only had 6 to 9, and we had to do some rationing about the tocilizumab. We gave them only steroid. Now, we gave them 40 milligram IV BID, and then after first dose, I was checking if the fever comes again. If fever doesn't come, I don't give extra dose, but if fever comes, then I was giving extra dose of 40 milligram solumedrol to stop that storm. Now, steroid, it works generalized, and that's why it's not specific. Second thing is it works slow. It doesn't work as fast as tocilizumab. So that's one of the problem with steroid is. Secondary bacterial infection with steroid, it happens when it is continuing longer. It happens, but then we are able to take care. No one dies from infection. We are able to take care of them. But what I am finding is the patient who got tocilizumab steroid versus the patient who got only steroid, the patients who come back to me in ICUs are those who are only on steroids. So to me, tocilizumab is more effective in using it. Is steroid better than not doing anything? Yes. I can tell you for sure that if you do steroids, even at that point of time when they are 6 to, I don't want you to, frankly speaking, again, I'm speaking from my experience. I don't think we should jump on giving steroid at maybe room air or 1 or 2 liters, but nasal cannula increasing, going to 6 liters. We will not be doing ABGs, will not be doing frequent chest X-ray. That's why, oxygen is a very good marker in these patients, saturation. So I would say at 6 liter point, if we are not giving tocilizumab, steroid is something to consider, and it will definitely save you multiple intubations. Other thing I want to say, I completely agree as what Dr. Puri was saying. Try to prevent intubating these guys. We are intubating. You will see these patients sitting and talking to you very hypoxic, but not very tachypneic initial on. And, you know, I still, at this point of time, I just left ICU just to talk to you guys, but I have, you know, what they do actually in my whole, we have like 6 units running. Anyone who needs to be intubated, they think, like my fellows think that we can save them, they bring it to my unit, because you know, that's what I do. I bring them to, I do the awake proning for them. I give them, you know, and then, you know, most of them will get intubated at night time. I'm telling you, they will hypoventilate at night. You guys don't have that much problem, but I'm very sure obesity can still be a problem in India. What I was seeing earlier, that every one of these hypoxic patients was getting intubated at night time because they are hypoventilating. It's not real AA gradient. This all hypoventilation, and these people were jumping to intubate them. So what I started doing is, I see anyone with belly, I ask them to hyperventilate. So yesterday there is a patient who's 82 on 100% FiO2 on nasal, on high flow, on high flow. And I talked to her, she's able to talk to me in full sentences, and everyone is saying to me, intubate. So I said to her, I had broken Spanish, you know, respira profunda, and, you know, she went to 100%. And then those guys, because these guys are hypoventilating, so don't jump to, sorry, the basically crux of this whole story is, don't jump to intubate these guys. See if there is a hypoventilation going on. These patients have very good compliance. They are not very tachypneic. It's more of a VQ mismatch without any, you know, ARDS kind of picture, which will make them tachypneic. Try to use high flow if you can. Means I don't know what is the policy we will be doing in PGI. To me, we are using it in negative pressure room at this point of time, but there was time we were not using it negative pressure room and no one got sick. Okay, so, but use it. Do awake proning, works perfectly. Very good in these patients, specifically obese patient. And then we could do head and up awake proning. Diurese them as much as we, maximum, and give them tocilizumab steroid. With 1 or 2 days, these patients come off high flows. And we are able to prevent multiple intubation. And that should be our goal in India. We don't have enough ventilator. I'm no one to speak, but I know being there that, you know, we don't have that many ventilators if everyone starts getting sick. So that should be our goal. What we have acquired actually now is something called, I don't know if I'm going overboard, Dr. Puri, I can stop if you want me to. So I can stop if you want specific questions. I can't hear you. I think you are on mute.
Carry on.
Oh, okay. So other thing, what we have, yes, go ahead.
No, please go ahead. I think I was only thinking after that. I'll tell. Please go ahead. Sorry.
Okay. No worries. So what we have acquired just now are the head, those helmet oxygen. I think they came from Italy or somewhere. I don't know. Or Apple made it for us, and we are entering into trial with those. But they are very good. Specifically, I was saying is it's a very, very simple design. There are 2 oxygen and 1 air which goes into it. It gives you even little bit of PEEP, but it works perfect. And we are working on to see if we can go into some randomized control trial with this and show benefit of it. But we were able to see PEEP, developing a PEEP with it. It is able to you don't need negative pressure room. Everyone around you, everyone is spared of the virus replication fear which everyone has. I don't know how easy it will be for us to get it in India, but I think Dr. Puri was saying he was working on it. But if we can't, I'm telling you, this is not a very difficult design. We need to get few people around, like, who engineers around, and just make it. We just have to make it like a vacuum thing. Again, it might be easy for me to say, not easy to make. But, if we are worried, that is something we can start working from get-go, and it could be a very good design. That's what I have to say. Prevent intubation, try to predict it early, treat it early. The main point about steroid is this: if you give steroid when they are already intubated, early intubation maybe, but they are intubated for 7 days, it's useless. And we know it from ARDS trial in the past. We know it from influenza trial, what happened. That's why everyone is freaking out. It is the timing. It is timing to give it at that point of time when you are able to prevent that inflammation going on. And if you give it early, you'll be able to make impact. Will 30% of those patients might need additional antibiotic later on? Maybe, but none of get killed from any infection. To me, tocilizumab is much better along with steroid, then doing steroid only. But if there is nothing, then steroid is something we should try very early. I'll stop.
Dr. Puri?
Yes, sir.
I think just maybe use a little your last presentation, your colleague, and then we can have some questions before Anoop and
Yes.
Sandeep. Please.
Dr.
Before that,
Rajarajan?
Dr. Puri,
Yes.
I have one slide or something before that I would like to
Yeah,
share
please,
as well.
please,
Whenever
please.
you have a time. Whenever you have time. Okay, thank you.
So, Dr. Rekha.
After.
So coming on to the shock part, which has been very well explained by sir. So it is defined as a when the hypoperfusion occurs with the hypotension only. So how we will identify the shock is when the mean pressure is less than 65 millimeters of mercury, increase in the heart rate of the respiratory rate, or when the urine output is less than 0.5 mils per minute, or there is a fall in the GCS of the patient, or it can be diagnosed when there is an increase in the lactate levels of more than 2 millimoles per liter with a cold peripheries. So the causes are most commonly is the hypovolemic shock, as we fear to give the fluids to the patient, and also these patients present with a fever and the diabetic ketoacidosis, and also there are the blood losses from the GIT. Other causes are the it can be vasodilatory because of the septic shock, sepsis, and because of the underlying ARDS, high peak airway pressures, the patient can have the obstructive shock. And because these patients mostly have the myocarditis and ischemia underlying in the cardiomyopathies, so these patients can also have the cardiogenic shock. So management of the shock includes, first of all, we have to start with the monitoring part. We will start with the very basic monitoring, that is, we will do the 12-lead ECG, non-invasive blood pressure monitoring. We will give the fluid bolus in the follow 500 to 1000 mils, and the expected response is that there should be a decrease in the heart rate by 10% and increase in the blood pressure of more than 10%. So if the patient do not respond to this, then we have to proceed with the invasive monitoring. That is, we have to proceed with the arterial line and the central venous pressure monitoring, and we have to start with the inotropic support. And the first choice of the drug is a noradrenaline, and the response will be seen in the 45 minutes. But still, if the patient is not responding, then the second choice is a vasopressin if the patient has a vasodilatory shock. And if the patient is having a cardiogenic shock, we have to proceed to dobutamine and the adrenaline. Along with this, we can also use the ultrasonography for the inferior vena cava diameter, if it is collapsible or not, if the patient will respond to fluids or not. And we can use the echocardiography. Next, please. So these are some of the echo images. First is of the hypovolemic shock, in which we can see the inferior vena cava, which is quite collapsible. So if we give the fluid bolus in this patient, the patient may respond and the shock may improve. This next picture is of the patient in which the cardiac contractility is very poor. The patient may have underlying myocarditis, or the patient may have underlying myocardial ischemia presenting with the cardiogenic shock. And next is the patient is having the dilated RA and RV. So maybe the patient is having the pulmonary pathology, that is, the patient may having the underlying ARDS, so presenting with the obstructive shock. So there are the other conditions also, like arrhythmias. The patient may have the arrhythmias, which in which we have to cardiovert the patient, or we have to give the IV agents like amiodarone. And there can be an indication of the renal replacement therapy. If the urine output continues to fall for less than 30 mils per hour for 12 consecutive hours, then it is an indication, and there are some other standard indications of the renal replacement therapy. And coming on to the blood transfusion, for the blood transfusion, we have to fill the blood requisition form in the ICU only, and that has to be sent through the email to avoid the contamination. And then the transfusions has to be done accordingly. Transfusions of the packed cells if the HP is less than 7, or FFPs if the patient is bleeding, or if the platelet count is low, then we have to transfuse with the platelets. Normally, we do not do the nebulization of the patients in ICU, as it is a very highly aerosol generating procedures. But only if the airway resistance is high and the peak airway pressures are high, we may need to nebulize the patient. Coming on to the weaning and the extubation part, the standard protocols has to be used for the weaning procedure, as extubation is a very highly aerosol generating procedure. So all precautions has to be taken off. The leak test has to be done before the extubation, and we have to clamp the endotracheal tube even before removing out from the mouth of the patient. The non-invasive ventilation can be used for the COVID-19 negative patients. And then how do we de-escalate to the non-critical area if the respiratory rate is less than 25 breaths per minute, if there is minimal or no requirement of the vasopressor, and the room air saturation is more than 94% or more than 96% on 1 to 2 liters per minute of the oxygen, and the patient is clinically stable for at least 24 to 36 hours. So,
Dr. Puri, I think we can have some kind of now questions.
Sir, before that, I just want to show the helmet which Dr. Anup was talking of. Can
Okay.
can I share the can I share my screen?
Yep.
Yeah, you can share your screen.
We are not able to see.
So this is the helmet, if you can see. So are you able to see it?
Yes, we are able to see it.
Okay. So I have asked somebody, and somebody is really aggressive to maybe in a couple of weeks he will be ready, maybe before that.
Yes.
And
No.
so it is need to be connected to any CPAP machine or ventilator and just give a positive pressure. We are also building a local made CPAP machines and a couple of holes to for the lines if there are, or some peak valve if we can include in this. So with this, I'll Dr. Talwar wanted to have some questions. I'm just removing.
No, I thought there are. I mean, if some, I'm sure you are there. Then Dr. Kataria, Dr. Anup. I think if there may be some kind of a questions to them. I'm not an anesthetist, so I might ask something different from the angle of management. But I just like to see if anybody wants to ask any question from Patiala. I think Dr. Sandeep, welcome. I mean, I'm Dr. Talwar. I'm a cardiologist. I was in PGI earlier.
Sir, he knows you very well.
Okay, that's fine.
I know you very well, sir. I know you very well.
So I think
you only recruited and ran away.
Oh,
hello.
Sorry.
Hello.
You recruited and he ran away.
Oh, it doesn't matter. I think, but they're doing a wonderful job. Sort of, Dr. Anup, this is mainly we have our teams from Patiala, Amritsar, for the Patiala Medical, the Punjab kind of facilities where we have. I thought they should have the benefit of, I requested Dr. Puri, and I'm really grateful that both of you are spared time to join us. I hope I'm audible.
Yeah.
Yes.
So there is
yes, Dr.
one question.
Yes, Dr. Bishbone, who is a professor of cardiology in Dayanand Medical College, who was my former colleague in AIMS Delhi. He's the one, I think, he's the force behind organizing everything for the. Thank you so much, Mohan. And Mohan, I think we can have.
Yeah, sir. There are some questions. I think some questions are coming. So, Sanju, can you coordinate that question?
Yeah.
Any questions, sir? Anyone from Patiala?
Ask a question. You can just unmute and ask a question.
Hello.
Hi.
Yes. We're listening.
Good evening.
Yeah.
It was wonderful talk. Just I want to have one comment and the questions.
Yeah. Dr. Purushottam.
Dr. Puri, the helmet mask. There are two types of masks coming. One is a single piece, and other these are two-piece helmet mask. The single piece helmet mask is really difficult to use. We have tried it. And secondly, about the question, what about the patient who was coming with the pulmonary hypertension, like a moderate pH, then titrating with the PEEP and the fluid and a little bit because nitric oxide and other things are not available. Even trying with the butamine and other things may be difficult. What would the fluid and the titration can be used to handle this pulmonary hypertension?
I think Anup, you can take.
Okay, this is question for me. Yeah, so if you are talking about COVID-induced pulmonary hypertension, I'm not seeing it. Doesn't happen. So you will not see anyone with pulmonary hypertension because of COVID. Second thing is, if these patients are coming early, I keep saying, I think everyone talked about this ARDS in the beginning. They are not ARDS, so you will not have right ventricular dysfunction, which happens in ARDS, which is not which can happen. But third thing is, if these patients are intubated for a long time, then these patients can develop this sort of right ventricular dysfunction, which we tend to identify just by doing bedside echoes in these patients. And they will have right ventricle bigger than the left side. If that's what is happening, then there is always the nitrous oxide which you can use in these patients, and that's the only point in ARDS which has been shown, or Flolan you can use. To me, if you are having a renal failure patients, then try to avoid nitrous oxide. I would definitely try to not give fluid to these patients at all. There is no reason to give them any fluid. These are the patients who will go in shock if we give them more fluid, because they will be impeding with the left ventricle filling if we give more fluid because of the right.
So there is just one question from Dr. Puri. Sir, Dr. Gurpreet is asking, why not use steroid early? Hello, Dr. Puri?
Yes. Well, I think Dr. Anup very well said that IL-6 inhibitor is the drug of choice with whatever they have experienced. Wherever that is not available, using steroid may be another thing, but using it early is more important than waiting for patients to deteriorate to the extent of hypotension and severe hypoxia and putting on ventilator. Dr. Anup, can you just explain, reiterate what I am saying?
Yes, Dr. Puri, please call me Anup. I completely agree. You know, there might be some steroid trial which might come later on where they will say no steroid caused increased mortality, but we have to look at the timing. I can tell you, and you know, I have actually finished all our data for 1 month, and I can tell you preliminary data. Someone who got tocilizumab and steroid, they are much better. And our numbers tells you this. Our numbers tells you that these patients' mortality as compared to any other hospital around us, like our sister hospital, which is a very much bigger hospital than this size, have a mortality, ICU mortality of 70%. Anyone who goes 70% mortality. So yes, please give steroid. If you not giving tocilizumab to these patients, give steroid only, but give them early, but give them only, you know, limited dose, and make sure that you rule out secondary infection after 4 or 5 days in these patients if you give it. Some of the patient might need more than 5 days, so you have to decrease the dose at that point of time. Some of the patient 3-5 days is okay, but that is all of a clinical judgment. Sorry if I went too much.
So there is just one question for you.
I want to add.
Yeah.
I want to add to this, Anup. Dr. Puri, I want to add to this as well. For steroid, I'm very big believer in steroid, and I totally agree with Anup as well. So I was talking to my previous institute where I trained, and before they actually have discharged around 1,000 COVID positive patients. And I was talking to one of the attending there, and then earlier on, they were trying to use the steroid when there was a biochemical marker elevation suggesting of inflammation or cytokine surge. But lately, they have started using it more empirically whenever there's a PF ratio less than 200 or there's a evidence of hypoxia. So only hypoxia is their trigger, and they are using some little bit higher dose than Anup mentioned, is 62.5 milligram BID, and depending upon how they respond, they can continue up to 5 days or no. And also at my local institute, because we are now running into some availability issue of solomedrol, which is methylprednisone, we are now resorting to 10 milligram of dexamethasone twice a day in a patients who have hypoxia and who has a full-blown ARDS. We are trying to use the methylprednisone.
There is
I don't know about the.
There is one question for you, sir, both of you, from US, that are you taking HCQ as a prophylaxis? There is a question from Freethcourt.
No.
Yeah. No. Yeah. Both of you.
No data. No data.
Okay. So there is another question for Dr. Puri. That is there any role of Monte-Ducast in these patients?
Yeah. Yes, sir. I have asked. Yes.
Yeah. Sorry, sir.
Are you talking of antihistaminic?
No, it's a Montelukast, sir. I'm talking about Montelukast.
I don't know.
I have no idea. I just wanted to
So I
get
think
into the steroid thing.
Puri, I don't think there is any role of this, whatever I have read. So I think you can say good.
Yeah.
Sir,
Next
I
question.
am just asking for about the probability, sir. Yes,
No,
I am
no,
Dr.
doctor, there
Joshi,
is
medical
no.
superintendent.
Sir,
Okay.
I'll just try to explain here.
Yeah,
A lot of
yes, sir.
people are talking of, well, a lot of biomarkers. I'm not expert in all these things, but to me, the only marker is oxygen tension.
Sir. This is season of harvesting. So I am just asking as a prophylactic or as a curative part. I am just asking
Well,
as a
I
probability.
think Anoop, as a pulmonologist, will be able to tell.
I would not. Yeah. So
Yeah,
if you
yeah.
ask me, have I used it? No. Will I
Okay.
ever use it? No. I don't think
Okay.
there should be any role of Montelukast in this one.
Okay.
So
Okay, sir.
we have
So nice.
Dr. Vishal Chopra from Patiala. He can explain if there is more query. Vishal. So okay.
I
So
think
if there
Dr. Puri wanted to clarify something about steroids,
Yeah,
if I'm not wrong.
I'll just.
One query regarding steroids.
Yeah, somebody was asking that if the TCZ is not available, can we give nitroxazamide? One last question. Dr.
Don't think there's
Sandeep?
any data, Mohan, on this.
Yeah, sir, there was these are the questions which are coming on chat, so I'm just coordinating that.
Okay, so should we?
Thank you, sir.
Sanjay Jain and Dr. Vikas Suri, our colleagues from PGI, they are the expert in this. They are internists, and they'll be able to say anything more on steroids, because ICMR guidelines say not to use steroid, and everybody else says use steroid. And even in our patients, we are reluctant to start steroids in spite of, and we are using it as last resort. So Dr. Jain and Dr. Vikas, are you your opinion?
Sir, I'm Vikas
Vikas.
Hi, sir. So whatever data Dr. Anoop has said is, we should understand, we should not, we should prevent intubation. That is the main thing. Use of hydroxychloroquine or any other drug like leucomide, there is no data. There is such infusion data about there is trials having contradicting data about that. And as Dr. Anoop has said in one of his previous webinars, all of these work where there is no hypoxia. Once hypoxia occurs, none of these work. So our main aim is to
Okay.
So should we close, Mo?
Yeah, yes, sir. There is just one last question from Dr. Mahajan. He is asking that what is the indication of spine and prone? When to ask for a prone ventilation? That's the last question, sir.
Should I answer it? So
please.
I think, we are doing two kind of proning. As I said, my goal is not to let these patients get intubated. So I do awake proning for these patients. So those are the time anyone who is to me, anyone who goes into on non-rebreather, we tend to prone. We have very successful and try to take care of their inflammation early using tocilizumab or steroid and prone them early. And again, the next proning on ventilator, you all know the same, PF ratio 150, and although I don't have to go in detail of that, but yes, awake proning, anyone who goes on non-rebreather, we tend to do awake. Few of the patient doesn't do well with awake proning, but most of them, they do well, and we are able to prevent intubations.
So
I'd just like to add that
Mohan, should we end it now? Okay.
Yes,
well,
sir.
I think, and Dr. Puri, I must thank you, and Dr. Sandeep Kataria, Dr. Anoop Singh. I think it's very impressive to see their result. Few days back, I was hearing to a Japanese kind of discussion where they mentioned that is only 20-25% of the patient they can deventilate. Whereas I think your results are very impressive. That gives a lot of hope. I think because of probably the learning which is occurring from these patients is helping. And I think the most important point which I think Anoop has mentioned, try to avoid ventilation. I think that is the major thing, that whatever kind of we can try to manage them and do some kind of medication, whatever we have today, I think. But anyway, thank you so much, both of you. And I think, Puri, you do
Dr.
have you recorded it, Dr. Puri? So
Sir,
we can
I recorded it, sir.
So I can get Vishwan, I think you can. We can give this pen drive to all the places in our heart critical care teams in the Punjab.
Okay, okay, sir.
Yes,
sir. I would like to. I would like 2 minutes. 2 minutes.
Please go ahead, player.
Okay, okay. So okay, so just 2 minutes, guys. So the way I see it, actually, apart from being a clinical problem, it's more of a public health problem as well. So I had a slide which I want to share. I don't know if I can share. Let me just go into here. Then the thing is, we need to work on the logistics based on local local. Where is it? How can I share the screen?
You can talk, sir. You can talk.
It's good.
You can talk, sir.
Yeah, yeah.
That's
right. Can you see my screen now, please?
Yeah.
We can.
Can you?
We're getting.
So, okay. So basically, can you see now?
Yeah, it was clear last.
Okay. So So basically, what I believe is that we need to think beyond the critical care part of this also, as because I divided into 4-point preparedness. Number one is we have to have some sort of pre-hospital care in place. Like let's say the patient gets sick at home, because I have hearing stories, then patients, they don't know where to go. So that can be coordinated at a village or whatever ward level, so that they know which hospital to report and where to go. Second important factor we come into is that once we had a rush, that we were struggling with the patient flow. So we need to have some sort of plan. So how we can manage our patient flow. So where the patient gonna come, and direction and signs for them to how they're gonna navigate the whole hospital. And third point is actual hospital care. And we should not at the same time forget about the fourth part, which is family and the post-hospital care, post-discharge or post-death care. Regarding the family care, what I think I have seen in India is that we don't proactively talk with the family. So I think setting up some sort of a timing for family briefing over the phone, and also involving our psychiatrist friends to help with the alleviate anxiety and talk to the family, and also set expectations very early on, because these patients, like Anup said, they get really sick really quickly, and the mortality rate we are seeing now is climbing. So those things we also have to take care, because it's not only the critical care, is also the public health problem, and we need to be making sure that we also address those issues as well. As far as patient anxiety is also concerned, we can also offer some sort of help over the phone while they are in the ICU awake, and when nobody's talking to them, nobody's coming to see them more frequently than ever. Thank you.
Thank you.
Well, I think that thank you very much. I will just summarize at the end. Ventilation, though the intensive care was the main topic, ventilation is, everybody is interested in ventilation. I think if you can avoid ventilation, that's the best, because problem starts once you start ventilating. Who's going to take care of the unconscious patient with the 3-layered dresses? With you can't move much. The attendants are not there to help you. So if at all we have to stop, prevent ventilation, and early use of drugs which can prevent hypoxia or cause prevent the cytokine release or whatever the mechanism, because still we don't know what is the exact mechanism. Though there is cytokine release, but what is the exact mechanism of hypoxia? Is it thrombosis? Is it pneumonia? Is it inflammation alone? Is it ventilator-induced injury, or it is a hyperventilation-induced injury? Whatever it is, the saturation monitoring, rather than waiting for 90% to saturation drop, I will suggest, I don't know, my colleagues, they still don't agree, that if patient saturation on room air, if there's a drop of 3 to 4%, whatever he had the baseline, I think we should give steroids or what is IL-6 in it. And proning is a very good thing, because that will prevent institution of ventilation unnecessarily, just based on the hypoxia saturation on the supine position. With this, I think I thank you very much. Aim of this whole topic, whole seminar should be how to avoid ventilation.
Thank you. Sir, listening to you is like a meditation, sir. Okay.
Okay, thank you, Puri. Thank you so much, and
Thank you, sir.
thank you so much for of your colleagues as well as both Sandeep and Anup. Thank you. Sir.
Bye.
Okay.
Thank you. Thank you, everyone. Bye.
Thank you.
Okay,
Thank you, everyone.
Let us hope that this ends soon.
Yes,
Thank
sir.
you, sir.
Right.